Hello, my name is Corey Langer. I'm the Director of Thoracic Oncology at the Abramson Cancer Center and Professor of Medicine at the University of Pennsylvania in Philadelphia. And my talk today will focus on tackling EGFR exon 20 mutations, clinical challenges, and new insights. EGFR exon 20 insertions constitute about 4 to 10% of all EGFR mutations in advanced non-small cell lung cancer. This may be limited to some extent by testing type, with newer platforms actually better able to identify these less common mutations compared to the more common sensitizing mutations in exons 19 and 21. Unfortunately, standard tyrosine kinase inhibitors have very limited activity, and compared to other EGFR-positive non-small cell, the prognosis is generally worse in those with exon 20 insertions. If we put this in context, EGFR exon 20 insertions represent a relatively small slice of the overall non-small cell pie, certainly a lot less common than the sensitizing mutations and less common than KRAS, but on par with other rare molecular abnormalities, including BRAF, HER2, RET, and TRK, most of which have dedicated approved agents by the FDA. In-frame base pair insertions in exon 20 result in constitutive activation of EGFR, but unlike classical activating EGFR mutations, they are associated with de novo resistance to first-generation TKIs, and this is likely due to their position towards the C-terminal end of the EGFR C helix, forming a wedge that prevents reorientation in the C helix to the outward inactive state. In so doing, this essentially locks the EGFR molecules into an active conformation in the absence of ligand binding. In contrast, a small minority of exon 20 mutations occur before residue 764. A763 is one example, and these are, in fact, sensitive to TKIs. In contrast to sensitizing mutations, cell viability in preclinical models is preserved when exon 20 and T790 mutations are present by and large. The exceptions, as shown here, include A763, where in the face of inhibitors like erlotinib, cell viability is radically reduced compared to the rest of the group. The big question is how this translates to patients. Prognosis is generally poor. If we look at progression-free survival for exon 20 compared to exon 19 and 21, the sensitizing mutations is far less. And chemotherapy, by and large, works far better in this group. Patients can be treated and be maintained on chemotherapy generally much longer than they can on first or second generation EGFR TKIs. How does chemo compare to TKIs in patients with exon 20 mutations? This is real-world data from China. If you look on the left-hand panel, first-line chemotherapy doing far better than first-line tyrosine kinase inhibitors with respect to progression-free survival, with a p-value of less than 0.001. Intriguingly, in the second line, very little difference. So TKIs, I would argue, should probably be reserved for second and third line, at least conventional agents that we have experience with. The question, of course, occurs whether bevacizumab has any effect on outcome in patients with exon 20 mutations. If we look on the left, in the first-line setting, the addition of bevacizumab to chemo seems to make little difference, with p-value of 0.221, although there may be an early benefit with respect to progression-free survival. Yang's data presented this year, published in Lung Cancer, shows, however, a different outcome in the second-line setting, the addition of bevacizumab to chemo producing significantly improved PFS compared to chemotherapy alone with a p-value of 0.013. In addition, this year at ESMO, Tamaris and colleagues conducted a systemic literature review with nearly 4,000 records. This included 5 clinical trials and 32 case series. Outcomes were generally poor. The best outcomes were seen with chemotherapy either alone or combined with TKIs, with response rates of about 28%, PFS of 5.5 months, and median survival of 18.6 months. For those treated with TKIs up front, the response rate was lower at 16%, median PFS PFS just 4 months and median survival just north of a year. And immunotherapy in a very limited cohort of just 29 patients, outcomes were worse yet. Response rates of 10%, median PFS of 3.2 months, and median survival of 7.5 months. But it should be noted that this real-world data is uncontrolled for line of treatment, performance status, and other factors that may have a bearing on outcome. The big question is whether the current standard of care for non-small cell lung cancer in patients who do not have an actionable target applies to exon 20. Certainly in those with high PD-L1 immunotherapy alone or chemoimmunotherapy is the standard, but it's not clear if this makes sense in EGFR exon 20, particularly with our experience with the sensitizing mutations where responses are low and we may actually have a deleterious effect, particularly when combined with TKIs. Chemoimmunotherapy certainly could be considered, but is adding pembrolizumab the right approach? Might there be a preferential role for bevacizumab? Certainly the data in second line suggests that. Or should we consider an IMpower 150 approach, melding immunotherapy with angio inhibitors and chemotherapy, a PAC-carbo, atezo, bevacizumab regimen? Certainly IMpower 150 included some patients with exon 20, and the response rates and survival in that group seemed quite favorable. But finally, we are on the threshold of new TKIs and monoclonal antibodies that target exon 20, and this certainly should be the focus going forward and will be the focus of my second part of my talk.